when my patients told me, the first 12 patients said, I put my finger, my tongue, a pencil eraser between my front teeth, it feels better. I decided I was going to see what happened if you did that, actually separated the back teeth and only the front teeth touch. Then I thought briefly, because I was very experienced with taking orthognathic, making orthognathic splints and orthognathic surgery, and patients having stuff in their mouth and still, being needed to function and talk. So I just gave a little thought, what kind of device could I design that would be usable, simple, that just separated the back teeth, but allowed the patient to function, to use the device 24/7, to speak with the device. Can't chew with something like that in your mouth. And that's the design that I came up with, which is nothing more than, a flat anterior plate with enough other portions of the device that would make it feasible to retain it. And ball clasp was the first thought I had, using ball clasps. Now we've done R&D to figure out we can do away with the ball clasps and make the device virtually, using a little change in the design for just retention. But the overall concept is, where can you, first of all, would the device fit over the lower teeth, the lower arch or the upper arch? Well, I can promise you, with my experience as an oral maxillofacial surgeon, something that goes over the lower arch, I don't care what it is, soft, hard, partial, complete, it's a mess trying to speak with it in your mouth. You're not going to, it's not going to come across. So, the thought process was, well, it's going to have to be something in the maxilla. I had a lot of experience using devices with cleft palate kids, oral devices, palatal devices, a bilateral cleft, bone, palatal bone, whether unilateral or bilateral. Often I made, just a simple insertion into the palate to hold the segments apart while the bone graft was healing. So I was very familiar with oral devices that were used for cleft palate kids.